The method of choice in the management of chronic infections is exchange arthroplasty. The exchange arthroplasty can be performed either as a one or in a two-stage setting. But since the first implementation of mixing cement into bone cement in the 1970s, the endoclinic, the focus of our discussion today, has collected over now or followed over 85% of their infected cases. The one-stage exchange arthroplasty for the management of PJI is a critically important issue. And one, especially in times of limited resources and access, may become the new gold standard. But let's have a discussion, an evidence-based discussion with a group of investigators who are more than thoughtful and have thought very carefully and deeply about this. Let me introduce Mustafa Senik, an attending orthopedic surgeon at the Endo Clinic in Hamburg, who currently serves as the Research and Fellowship Director. I will have him at this point introduce our keynote. Welcome, Mustafa.
Thank you very much, Mo, for the invitation, and I'm really excited for this next 1 hour. I would like to introduce my chief, Professor Thorsten Gerke. He is also my mentor. I met him first time during my rotation 2012 in Endo Clinic, and he's the leading chief physician of Endo Clinic, and since 2012 we are working really closely. I went back to my university hospital, but I recognized very early that this was the wrong way, so I went back to Endo Clinic, because if you work in Endo Clinic, you have to work, you see the difference, and then you have to go back. And during this time, we worked very effective on most or very huge papers. And I was also part of the international consensus meeting. Professor Gerke was the organization together with Professor J. Parvizi, and it was a great honor for me. And I learned also operatively and also about research so many things from him, and I would like to thank him for this opportunity.
Yeah, thank you so much. Thank you so much, Mustafa, for this really great introduction. But I must say, first of all, I'd like to thank Mohit because he has organized this really, really fantastic, this exciting event. And I see surgeons from all over the world, my friends from India, Alberto Cali and some others are here, the biggest surgeons all over the world. And so it's your work, Mohit, to bring them all together and in this fantastic format. To be honest, I'd like to congratulate you for this, because it's small, as you said, and it should be as interactive as it could be. And I see many Indian from, and Idemar is also there from Brazil, so it's wonderful. Mustafa mentioned it already. Let me say 2 words about Mustafa. Mustafa came to us in 2012, and Mustafa is one of the really rare guys all over the world who was able to write a complete paper overnight. And he is publishing a lot, more than 100 papers, 150 probably in the meantime. And he is young. He is 30 years younger than me, so he has a great future. So Mohit, thank you so much again that you allowed us to give you a presentation about our treatment of periprosthetic joint infections at PJI. And I like to give my talk now, and we titled the talk One-Stage Revision for Periprosthetic Joint Infections and then the New Gold Standard. It's a little bit provocative, but you will see at the end, after Mustafa showed you all the literature behind 1-stage, 2-stage, probably we are true. As we all know, the PJI is the worst complication in TJA. It's a catastrophe for the patients and for the surgeon as well. And so we have really a big issue, and sometimes it's really life-threatening. if you see this graph, it's come from Jay's group in Philadelphia, which shows you the 5-year survivorship of PJI, which is worse than many cancers like testis, Hodgkin's lymphoma, melanoma, or breast cancer. So it's really a very, very, very serious complications. Due to the time, limited time, I'd like to talk only about treatment. Probably on a later event, we can talk about diagnostics and so on. So let's talk a little bit about treatment. Treatment of PJI can be very various. So there are many ways are leading to Rome. You can choose the one stage, you can choose a 2-stage, just antibiotic suppression, fistula persistence, resection arthroplasty, or to perform a DARE. This man is a man who founded the endoclinic in the middle of the 70s, but he was also the guy who, this is Professor Buchholz, who implanted the first total hip replacement in Germany in November 1963. You see here the implant and the X-ray. This is now 57 years ago. And he became really fascinated by joint replacements, and he worked a lot on it, and he went to specialize himself into this field. But he was very, very successful, but he had a big problem. And his main problem in the 60s were the rate of periprosthetic joint infections, which raised up to 6.3%. And so he came to the idea to admix antibiotics to the bone cement. And on the right side, you see his letter, his original letter from 1969, where he asks the company who manufactured the bone cement, could we add antibiotics to the bone cement to reduce the rate of periprosthetic joint infection? And he was successful. By admixing antibiotics to the bone cement, he could reduce the infection rate almost down to 0. He published his first data already in 1970. The goal of the antibiotics in the bone cement were to protect the implant from recolonization of remaining bacteria. And this was the birth of the one-stage exchange by using antibiotic-loaded bone cement. And since that time, as Mo had already mentioned, in 85% of all our PGIs, we perform the one-stage, in just 9% the two-stage. In 4%, we try to save the implant by performing a debridement and retention of the prosthesis and antibiotics, their procedure, and here you can see the rest. Our philosophy is, if there is a foreign body infection, which is the PJI actually, we must exchange, we must remove the foreign material to control the infection. There's one exception. The exception is a post-op acute infection. That means less than 3 weeks after reimplantation, after implantation of the prosthesis. Only in this very short period, during the first 2 to 3 weeks, it is possible to destroy the early biofilm, because in this very short period, the biofilm is vulnerable. And then you can try at least to perform an irrigation and debridement, which is called since 10 years DARE. We perform it since 40 years in the meantime. All periprosthetic joint infections that occur later than 3 weeks after implantation, in our opinion, should be exchanged. The foreign material must be removed, and as Hippocrates already stated more than 2,500 years ago, ubi pus, ibi evacuo. Where there is, we can translate it, if there is a foreign body and an infection, you should remove it. But unfortunately, not only in Germany, but there are many, many countries where it is a very sad reality, because this is, for example, is a young woman, 36 years, periprosthetic joint infection over about 10 years with 87 revisions without removal of the implant. That's a catastrophe. Another case here, for example, from Italy, where the surgeon was not able to remove the distal part of the prosthesis. He just put a spacer on it and it failed. So you have to be very radical, remove all the foreign bodies, and then you will be successful. If you try to stay with the implants in late infection, your success rate, at least according to the majority of the literature, there are some exceptions, is very, very low. And still today there is a question, shall we go for a 1-stage or a 2-stage? Today, the 2-stage is worldwide the golden standard, which is good, and I accept it, or we accept it, at least as long as the surgeons have a concept when they perform the 2-stage. There are many pros and cons, probably a little bit more pros for the 1-stage than for the 2-stage. Our algorithm in the endoclinic is very, very simple. There's a question, is the biofilm mature, as I mentioned? So if not, can you do irrigation and drainage? Yes, if yes, and you know the pathogen, and there are local antibiotics possible, and a radical debridement is possible, then we go for the 1-stage. If one of this is not possible, we go for the 2-stage. To make it more simple, the key of the success of the 1-stage is the preoperative diagnostics. Find the bugs. You have to know which germs are responsible for the PJI and the susceptibility of the germs. So make it even more simple. If we know the germ and the susceptibility, we go for the 1-stage exchange. If we do not know, we go for the 2-stage. Here are the key steps of the 1-stage septic exchange. I like to show it in a video shortly. Our protocol, this is the endo protocol. The patient comes to it for admission at the first day. Then we need 1 day for pre-preparation because many of the patients are multimorbid. So on the 3rd day, we perform the surgery, and in average, we dismiss the patient after 14 days. Here are the principles. We excise always the old scars. We remove any suspicious soft tissue. We remove any kind of foreign body, like little cement pieces and so on. Even if the implant is very well integrated, as you can see here, we have to remove it. And you have to be very, very radical. After finishing your debridement, you start with systemic antibiotics and you start with reimplantation of the new device. We use, in the meantime, a lot of trabecular metal, but we always use antibiotic-loaded bone cement. In this case, vancomycin and clindamycin, and cemented stems and cemented cups. This is our prerequisite, our philosophy by performing the 1-stage exchange. If you look at the knee, they are completely the same principles. You have to work in a very standardized manner. First, debride the soft tissue, then remove the implant, debride the bone, remove any kind of implant, and even the posterior capsule, which is sometimes a little bit dangerous, must be debrided very, very accurately and meticulous, and then you start again after finishing the debridement with systemic antibiotics, change all used gloves, instruments, and so on, and reimplant a new device with antibiotic-loaded bone cement. Same principles for any kind of prosthesis, hip, knee, shoulder, elbow, anything, ankle. So 1-stage means radical debridement. This is the main predictor for success. But what is radical debridement? It means removal of all infected tissue, where the main challenge is to find the interface to the healthy tissue, like a tumor surgeon who must find the border to the healthy tissue. And this needs a lot of experience and has a very slow learning curve. Radical debridement means if, for example, if the bone is completely infected, then you have to remove the bone because you have no chance to eradicate the infection in this case. Radical debridement is really the key of the success. And if you have to remove the bone, then you have to find a solution with long and special implants. Usage of pulsatile jet lavage is mandatory in our opinion. We do it always with polyhexanide solution. And then the microbiologist is in our clinic very, very important because he recommends us what kind of antibiotics we have to admix to the bone cement. This is not a cooking book. This is, every case is different, and the antibiotic therapy has to be tailored exactly to this case. So the key factors for the success of the one stage is, as I mentioned, a very, very good microbiologist, good cooperation with them, well-equipped OR, good ICU, probably a plastic surgeon, and most important, skilled and trained surgeon. Only a surgeon who is doing a lot of these cases is a good and trained septic surgeon. Otherwise, he should send it to the specialist. We have indications for the two stage. If we do not isolate the germs preoperatively, if there are no local antibiotics possible, if there are not no radical debridement possible, and so on. The technical issues and the two-stage exchange is always the spacer. First of all, the question spacer or girdle stone, but spacers have a lot of problems. And as you can see here, if you see these examples, there is no perfect spacer yet, especially in very obese patients. Or even if you do a girdle stone, it can up with a massive heterocopic ossifications, with a shortening of the leg, and with a lot of issues. I'd like to give you 2 minutes more to explain you what kind of spacer we are using. Typical patient here, you see the history, but we were not able to identify the germ. Normal case, nothing special, but no germ identified preoperative. So we are going, we call it 1 to the 1.5 stage exchange. That means we use, in the meantime, in the interval, a spacer which includes a bed cemented stem and the inlay of a dual mobility cup. I show it in this short video. So here's the acetabulum, you put in the cement, and after a while, during polymerization, hardening of the bone cement, you move the trial of the dual mobility liner until the cement is really hard. We use always high viscosity bone cement, and then by doing this, you create a shell of antibiotic loaded bone cement in the acetabulum, which is functioning like a cup. And then you do, in a very bad cementing technique, you introduce the stem, you wait longer, you wait 6 or 7 minutes until you introduce it into the femoral canal. Then you combine it with the dual mobility, as you can see here, with the head, put it all together, and then you have a very safe spacer without any risk for dislocation. The patient can move on it and walk on it with full weight bearing immediately. And this is, at the meantime, we did about 100 cases in this procedure with very good success. Surgical, the one-stage exchange is on the rise worldwide. Here, just as an example, I'd like to show you the numbers of surgeons from UK who did in 2005 the single-stage revision. This was almost 18%. 9 years later, already almost 40% performed the one-stage revision because they have seen the advantages. Because the two-stage approach has a lot of advantages, very high mortality rate in the interval. And this paper is a very, very good paper, beginning of last year, which looked after the quality adjusted life years. And here, it is an American paper, they mentioned that the one-stage revision produced much greater health utility. But now Mustafa gives you a much deeper insight into the literature. First of all, I'd like to thank you very much for your attention.
That was wonderful. Thank you so much.
So, thank you very much. It's a great honor for me to give a literature overview about the one-stage septic exchange. As Professor Gerke and Mo mentioned already, it all began here. So the first paper from Endoclinic was published in 1981 by Professor Buchholz. And the first results within the first 10 years without systemic antibiotic therapy achieved only 77%. But after including systematic antibiotic therapy, the success rate was beyond 90%. What about literature? So let's focus first on the total hip arthroplasty. There are a lot of research or a lot of papers, but if you look more in detail, you can see that there's a limited number of long-term results. So we have published last year our 10-year results after the total hip arthroplasty one-stage exchange. This was published in Journal of Arthroplasty, and if you look about the infection-free survival rate, we had a 94% infection-free survival rate. But if you look at the reasons for re-revisions, in total 25 revisions were performed, and the majority of cases was not a reinfection, was more dislocation. Because if you perform a radical debridement, you sometimes, if the bone is infected, you have to perform a proximal femur resection. You have, of course, a higher risk for dislocation. But you have the same risk also in the setting of a two-stage septic exchange. So let's focus now on the total knee arthroplasty. The same, it's very similar. So limited number of long-term results. Here's a paper published by our group from Akos Sahar. He was the first author 4 years ago, also 10-year results after the total knee arthroplasty, looking on 10 years infection-free survival, 93%. And if you look on 10 years surgery-free survival was 91%. So the next question is, why do one-stage exchange fail? So we did last year, I think, in my opinion, very important studies. First, it's published in JBJS American, and for the knees, and the other paper for the hips were published in Core. So I will start first with total knee arthroplasty cases. We did a case control study. So we looked for a patient. They were treated with a one-stage TKA from 2008 to 2017. So total number of cases were around 700. And we looked for the cases, they were re-revised due to any failure for any reason. So 93 cases were revised after the one-stage exchange. And we matched the cases by age, gender, and date of surgery. So 91 patients were included because 2 patients were excluded due to re-revision surgery in another hospital or without complete documentation. And 45 factors were compared between the patient and the controls for identifying specific risk factors. So if you look at the failures, the mean time to failure was 25 months, like around 2 years. And here you can see the red shows the reinfection, and the blue ones, the overall failure rates. And if you look here, the majority of cases were failed within 7 to 24 months. And if you look for the causes for failure in the knees, the highest number was infection with around 52%, followed by aseptic loosening, and patella problems were a relatively small number with 3 cases. It's 3.3%. So what about the risk factors? If you look for the risk factors, you have to talk first about the re-revision for any reason. And if you look at the top 3, you can see the isolation of enterococcus was with almost 90-fold higher risk. If you have a prior one-stage exchange, the risk for re-revision was also higher, and if you have more than 4 operations. So it means if you have more than 4 operations, they are really complex cases. And if you focus on your reinfection, you have the first 2 are similar. We have the top 3 was the persistent wound drainage with around 4.5-fold higher risk, but we have an additional risk factor for reinfections, the streptococcus. But if you look at the 2-stage literature, you can also find those germs like enterococcus or streptococcus as a risk factor for failure in the 2-stage septic exchange. So what about the hips? If you focus on hip, we found similar results regarding the reinfection rate, like the risk factors, also the germs or the 1-stage septic exchange. But in knees, the most common cause for failure was reinfection. But in hips, the most common cause for re-revision surgery was dislocation, as also presented in the 10-year results, followed by the reinfection. So to avoid the dislocation rate, we recommend to use a dual mobility cup in the setting of a 1-stage revision hip arthroplasty to reduce the risk of dislocation. We will publish this paper also very soon, showing that the dual mobility cup can result or can reduce the risk of dislocation. So this is also a very important topic, lengths of antibiotic treatment. Professor Gerke mentioned already, our microbiologist is giving us how long should be the antibiotic treatment. Usually we are performing systematic antibiotic treatment for 14 days. Here's a systematic review. I'm also one of the co-authors. So we looked for to identify if there is an optimal duration of intravenous antibiotic treatment. 21 studies were selected, and it means 643 cases. So there were 2 groups. The first group had the antibiotic treatment less than 4 weeks, like range 5 to 20 days. There were 320 patients in 12 studies, and their eradication rate was here 92.6%. And the second group was the antibiotic or longer antibiotic treatment with 5.5 weeks, like from 4 to 6 weeks. There were also a similar patient number with 9 studies. The eradication rate was a little bit lower compared to the shorter time interval, but there was no significant difference. But I think that the eradication rate here might be higher, maybe because the germs were not difficult to deal germs. That could be one of the reasons why the eradication rate in those cases are even a little bit higher. So in this study, we said we need multi-center randomized controlled trials to say which is the best or what is the optimal duration of intravenous antibiotic treatment. So Professor Bandari mentioned already that we are performing, and Professor Gerke said it also, in around 85% of our cases, if the patient fulfills the criteria, we are performing the one-stage septic exchange. There are more than 5 reasons, but I will only mention 5 reasons. Of course, besides the most important reason that the patient need only 1 surgery. So here's a study also published by our group together as a 2-center study together with the Rodman Institute with Jay Parvizi. So we looked for the blood loss and the transfusion rates in both procedures. And if you perform, of course, 2 surgeries, you have a higher blood loss and the need for transfusion rates. In this study, we didn't look for the reinfection rates, but we know already from other studies that the necessity of transfusion can result in a higher infection rate. Number 4, you have lower in-hospital complications. This is a study from our group. To be honest, we have 381 cases with 1 stage, only less number of 2 stage. But also in this, we found a significant difference for the acute renal failure performing the 2-stage septic exchange. Number 3, lower in-hospital mortality. Here's a study, also the same study which I showed one slide before. We had a lower mortality rate performing the 1 stage. If you perform 2 surgeries, you have, of course, higher risk for complications and also for the mortality rate. Here's a study from Norwegian Arthroplasty Register. They looked also for the mortality rates comparing like the 1 and 2 stage, and also in 90 days and 1 year results, the mortality rate was higher in the 2-stage septic exchange. Number 2, Professor Gerke presented this study already, so it's more cost effective. And as mentioned already by Professor Gerke, the 1-stage exchange gives a higher quality of life in patients with a 1-stage procedure. Here's another study recently published in Journal of Arthroplasty. This was for the knees. This is for the hips. So we have improved patient-reported quality of life in performing a 1-stage septic exchange. So let's focus on the most recent studies. Here's a study by our group. So what happened to the patient? They were younger. Here's a 10 to 24 year results after the 1-stage septic exchange in younger patients. We included only patients, they were younger than 45 years of age. And even in this young patient group, we had, even after so long time, we had the eradication rate of 96.2%, and the overall survival rate was with almost 77% acceptable or satisfying or comparable to the 2-stage septic exchange. Here are our recent published comparative studies with 1-stage versus a 2-stage, and in this study we had a higher eradication rate in the 1-stage septic exchange. Of course, there's a limited number of cases, only around 62 cases in total, and the follow-up time was short. This has to be mentioned. But looking on the clinical outcome, the range of motion was significantly better with the 1-stage septic exchange. Here's another study where also looking for the knee arthroplasty cases. It's they saw here again similar results in terms of eradication rate and functional outcomes, but you have, of course, advantage, especially only for 1 surgery, and as I presented already, lower morbidity and reduced costs. Here's a Norwegian registry I showed already in the mortality. I presented this already, and here we found also similar eradication rate for the 1-stage and the 2-stage septic exchange. Here's another study, single-stage versus 2-stage, and Professor Gerke showed already that popularity in performing single-stage is also higher in North America, and because this one reason is we have comparable success rate, but we have potential functional benefits to the patient and the decreased burden to the healthcare system. There is no really randomized controlled trial. This is a very important study which called the INFORM study. This was started in 2016. We do not have the results yet, but we are expecting it this year. It's very interesting to see the results about which type of treatment it's better or have a higher eradication rate or functional outcomes. We are looking forward to the studies. But focusing on future projects, we need large randomized controlled trials with following questions, which is better 1 or 2 stage. This is because this is in all the meetings always discussed. And what about the success rates according to the germ spectrum? I showed in our risk factor study that germs like streptococci or enterococci have a higher risk for reinfection. This is also for 2-stage septic exchange. So before we define indications or like contraindications for this type, so we need a large randomized controlled trials and the length of antibiotic treatment. This question has to be also answered in the future. Thank you very much for your attention.